All right. Like to introduce Dr. Hanzhang, an assistant professor, Department of Family Medicine and Community Health at Duke University School of Medicine.
Thank you so much for the lovely introduction. I'm very honored to be here with you today. So I know we're running a little bit behind, so I'll try to keep my talk on time. I think Dr. Power set a very nice stage for my talk, because what you conclude is basically having a diagnosed dementia in whether in the EHR or medical claims, that's not random. So we're trying to hear in the project when we present today is talk about the kind of pathway, the care process leading to a diagnosed dementia in the electronic health record. So, and also Dr. Amano, you present a lot about in terms of the benefit of obtaining a timely diagnosis of dementia, but for those who are clinicians, we understand obtaining a timely diagnosis for older adults, like clinical diagnosis of dementia, has been challenging for a variety of different reasons. I think there was a study done 2 years ago using the Medicare claims data from California, looking at timely diagnosis of dementia in the claim-based data source, suggesting that racial ethnic minority older adults, specifically Black, Hispanic, Asian, are less likely to obtain a timely diagnosed dementia based on the claims, and we're also less likely to have a more comprehensive workup compared with their white counterparts. But the question we're interested is basically, it's not random, so they wind up in the system somehow, but we don't quite know at a population level. There are qualitative studies being done in the past to look at the kind of the care processes leading to a diagnosis of Alzheimer's disease and related dementia in the for patients. So I was trained as a social gerontologist, often thinking about life course perspective is my go-to framework. And it actually provided a really nice way for me to think about, to conceptualize the diagnosis process of dementia. So how the patient is interacting with the healthcare system before an incident and ICD-9 or 10 assigned to the patient. So in a life course perspective, there's a couple of key concepts such as timing, duration, and sequence. So timing is basically can consider as a time of diagnosis, age of diagnosis, and duration is often can be considered as the time period between two critical events, whether it's from the recognition of a symptom to leading to a primary care visit, or it could be a hospitalization leading to a referral to a specialist visit. And sequencing is basically a series of events of that being played out on the timeline here. So I have the figure here actually illustrates several different examples of the care processes or pathways to ADRD diagnosis. A pathway A may be a kind of optimal pathway that we want patient follow, basically the symptom recognized by a family member, and they had an initial assessment done in the primary care setting, and then that will refer to AD specialty like neurologists or geriatricians that have done some blood work or imaging, and at that point, Alzheimer's disease diagnosis was made to the patient. But from prior qualitative studies and including our own, we found that racial ethnic minority older adults, specifically in our sample, Black older adults, are more likely to follow a crisis pathway. So they often like the pathway B and C here, their diagnosis actually occur more likely to a conjunction with a medical crisis, whether it's a hospitalization or ED visit due to heart failure or hip fracture, etc. So what we're trying to do, we're interested to see, now we have access to those EHR data, which actually capture patients' audio utilizations over time. We try to see if we can map all those kind of care processes purely based on the EHR data. So the patient population, so we have access to the Duke EHR, and the EPIC system was implemented, I think that was January 1st, 2024. So we're trying to identify the cohort, basically all individuals with discharge final diagnosis based on ICD-9-10 codes that exist in the Duke EHR system. And we limit a patient to 65 plus, because for early onset dementia patients, the diagnosis process or the care process might be quite different. And because the geographic area of this location, and also look at some preliminary data, we actually focus on those who self-identify as non-Hispanic Black or non-Hispanic white. And to be able to really make sure they are actually active users in the healthcare system, we limit them to have access to 1 clinical encounters in the electronic health system 2 years prior to their incident diagnosis of ADRD, and also to have a kind of more complete picture of capturing all the utilizations. We actually also limit those with a primary care provider on file, and because we know the limitation of EHR, and although in recent years, we're actually seeing more and more social determinants of health measures integrated in the EHR, but because we're looking at kind of a more historical period, so we want to be able to put some census data, the EDI, Dr. Klein presented this morning, so we further link the patients who have a valid NC home address in the system, so we can do some linkage with other data sources. So we end up with just over 3,500 ADRD patients. ADRD patient means have a diagnosed ADRD in online 10 codes, and close to 50,000 clinical encounters in our analysis. So I want to talk briefly about the study design. For those who are familiar with the longitudinal design, often think about we have a clear baseline, right? Then you look at things follow up over time. But how we construct the data was a little bit different. We'll actually start with the endpoint first, basically the very first ADRD diagnosis in the system. Then we're trying to trace back to kind of potential earliest encounter to see like then the whole design to fill all the gaps in between, the clinical encounters happen in between. And then for the part that really tricky was like the earliest encounter. So there are different ways we can go with that. One is to think about that will be the earliest encounter they have in the Duke healthcare system. There are different bias towards that. For older patients, they likely will have a longer period of follow-up compared with patients who just moved to the area or younger regarding their age. And another thing, at first, we're also thinking about whether we can use natural language processing, because with the EHR, we can potentially identify the kind of first indication of a memory complaint, etc. But with NLP, we actually found a very low yield in terms of how that's been documented in the EHR. So it's basically that's not a feasible approach. And so I'll talk about that later on. And also with the complexity of data, we actually only limit the traceback period to 2 years. And this is kind of the characteristic of a patients in our analysis. We actually seen some racial differences in some of the social demographic characteristics here. We see a slightly higher proportion of females in the Black sample, and a high proportion of individuals who are widowed in the individuals who self-identify as non-Hispanic Black. We actually didn't see the differences regarding whether they live in a disadvantaged neighborhood based on ADI or not, but we actually seeing a slightly higher proportion of non-Hispanic Black individuals who live in rural areas. And the diagnosed encounter type is basically the type of encounter of the very first ICD-9-10 codes, and that was signed. We're actually seeing quite a bit racial differences here. So for individuals who self-identify as non-Hispanic Black, they have like we have seen about a third of them, the diagnosis was made in a primary care setting, versus for non-Hispanic white, that's over 50%. That was being seen by AD specialty. We're thinking about neurology, neuropsychiatry, geriatric psychiatry, etc. And we're also seeing some differences regarding the number of clinical encounters within the 2-year period prior to the diagnosis. We're actually seeing a bit more a high number of encounters among non-Hispanic Black patients compared with non-Hispanic white. And to map out the care process, we're leveraging a data-driven clustering method called state sequence analysis. So this is a method that is born in the social sciences field to study the ordering of life course stages. And I will provide one example just in a minute. But in our setting, so we're trying to think about this for the diagnosis, the diagnosis process, the care process, it's also kind of a sequence of clinical encounters over time. So trying to see if we can apply the state sequence analysis in the EHR to identify the care process leading to an ADRD diagnosis. So conventionally, a lot of people use a state sequence analysis. It's not a new method, but probably new in this specific context. So a lot of people use that to describe the life course stages. Think about individuals who transition from being a children living in a being a child living in a home, transition into schooling, then starting their own family and transition to work environment into the workforce, then retirement, etc. So those are various well-defined life stages. So this is one example that done by Elizabeth Miata from UCLA, looking at life course of work family profile among women. But in our case, we're thinking about, okay, we actually can also define patient's state within a specific time unit. So a patient state in our context can be where the patient were on a given day. So we also kind of capitalize the possibility between among several different options, AD specialty, hospitalization, emergency visit, other specialty, primary care or home or no utilization. So I have an example at the bottom of the slide. Think about a patient of a given week. The patient can spend the first 3 days at home. So that's being shown here, basically the 3-day as kind of the white color. Then the patient had an emergency department visit on day 4 and got subsequent hospitalized from day 5 to day 7. So this kind of represents a sequence of healthcare utilization over a period of a week. So at first we think, okay, this is great. We can just pull all the data and we can just map out where patients were on a daily basis. Then we quickly realize, okay, this may be really complex. If you think about, we have 365 days in a year, and for 2 years, that's a lot of data and a lot of variety. And we actually did analysis and took forever to run those models just because of a complexity of data. When we stare in the data, we really couldn't make sense of that. I think partially because there's a lot of the non-utilizations that occurred during the period, and the utilization happened just so stark. So in what we think, okay, it might make more sense to not think about day as a time unit in analysis. So we transition to the week. Then we run into another issue, because a patient can actually have different, they can be in different locations in a given week. Then at first we try to basically map all the possibility of a given week. You can see this is kind of a color pattern here. And we run into the problem of also have too many categories or to make any sense. And also some of the colors, my co-investigators are giving me like a hard time to basically saying like, what's the exact difference between like a slightly lighter pink versus a slightly darker pink. So we thought, okay, this might not be the best approach either. So we thought about, because we're interested in the care utilization leading towards ADRD diagnosis. So all the different clinical encounters may actually carry different weights. So in our mind, having a visit to a neurologist or to a geriatrician might actually be more relevant to ADRD diagnosis compared with a visit to a ophthalmologist to some extent. So we actually came up with kind of a priority list to help us to kind of consolidate data into a weekly basis and assign patients given the kind of the type of visit they have on given day. So for example, if a patient, like I was showing before, spent the first 3 days at home, had an ED visit, then had a hospitalization for the rest of the week, and we think hospitalization may be more relevant to an AD diagnosis than an ED visit. So the patient can code them as kind of for that specific week as a hospitalization. We also did sensitivity analysis to change the ordering of this of the priority, and we also did some other analysis, basically looking at other specialty. We further that break that down to potentially OT and PT, which is somewhat more relevant to older adults with cognitive impairment, and we see a bit similar patterns, etc. So basically, that's a lot of decisions we made to construct the data to be able to really make the state sequence analysis work in this specific context. And also I was talking about earlier about what kind of the earliest indication here, and we made a decision that we're just looking at a 2-year period of the utilization patterns prior to the ADRD diagnosis. Just a little bit about how the state sequence analysis work. So we actually, once we have done the data, cleaning data management, we apply the optimal matching. That is also a method largely using social sciences to compare dissimilarities. And we also in the stage of generating the matrix of dissimilarity, we assess the minimum cost of changing from one sequence to another, and the deletion or insertion that would assign a cost of 1, and substitution. So basically, for example, the state will be a AD visit, and you substitute that to a primary care visit. What's the cost? So the cost was determined based on the estimated transition rates. Then, based on this pooled distance matrix, we use a hierarchical clustering procedure and word linkage method, and basically to cluster patients into different buckets in terms of how similar their care process look like. And then for those who are more familiar with latent class analysis or those kind of clustering method, you know the optimal number of clusters that's often determined based on some statistical indices, which is a similar case here. And I also want to make sure the optimal number with the patterns we're seeing in the data makes sense clinically. So basically, we also apply these kind of 2 principles when we determine the optimal number of clusters. So this is where we started after we cleaned up the data. And we can see over 3,500 individuals, and this is kind of their utilization pattern in the 2-year period before their very first ICD-9 or 10 indication of Alzheimer's disease and related dementias. You see, it's kind of all over the place. You couldn't make any kind of obvious pattern from that. So this is where we started. Then, and also want to also give you another sense in terms of how heterogeneous the data set we had is. Basically, this is just look at the top 10 peer process based on what we've seen on the first one. You can see the top 10 only account for about 2% of the entire sequence we have seen. You may think about for the bottom 3 look quite similar. They didn't have any utilization prior to, not much prior to their ADRD diagnosis. They just had another specialty visit right before their ADRD diagnosis. The only difference in terms of timing, whether they were seeing like 2 weeks or 1 week before the ADRD diagnosis, whether that matters or not. So this is just purely descriptive, but like when we do the clustering, those are things we want to consider, whether they should be different groups or they should be similar groups, just whether 1 week of difference of utilization, whether that matters or not. And based on statistical indices and also clinical, and also we look at each of the pattern. So the statistical indices give us actually the top 2 options. The first one is 7 clusters, as seen here, and the second best option is actually 20 clusters. So which is a lot of stuff here. You can see, you start to see some of the color differences and the density of the color, but still not kind of a clear picture. And this is not the way that I did some latent class analysis work before, but this is a little bit new to me because I have a lot of things to need to consider, and so does my team. So we actually came up with a kind of scoring sheet for us to actually go through each of the patterns in a way that we looked at each of the clusters described qualitatively in terms of the density, timing, color, and how the pattern looks like, because this actually helps us to think about whether, for example, for the 20 clusters we're seeing in one of the options, whether those are actually distinct different patterns versus these are just slightly different ones. And we also create kind of a flip book, because going from 7 different clusters to 20, it's basically, there are a lot of subgroups we want to see. So we actually go through each of the clustering options from 7 to 20, really to go through all of that to see whether we're seeing clear patterns, whether we really want to go with more clusters versus a more parsimonious 7 different clusters, but we actually end up with 7. So also we did some sensitivity analysis because as I mentioned before, we assign a priority of for a patient's state of a given week, whether that introduce some biases in the coloring we're seeing, because for AD visit or hospitalization, they'll get a more priority. If this is a way that we actually will populating more of the red or purple color as we're seeing here, so actually try different ways to dichotomize, not to dichotomize data, but to kind of assign patient state in different ways. For example, if we just want to see if we prioritize everything, like primary care visit will be the top priority. So if the patient had a primary care visit for that week, we just assign that week to primary care, whether we're seeing different patterns or not. So we did some sensitivity analysis to see whether the pattern looks similar or different. That was the primary care visit, and this is AD care visit. We're actually seeing our priority list was pretty stable, even with turn the color and on off. We see pretty much a similar pattern as we're seeing with all the different with original priority. And this is the kind of the 7 clusters we feel comfortable with, but in analysis, as we looked at patient characteristics, how that distribution looks similar, different across 7 different clusters. We found that actually the type 7, type 4 look quite similar. The only difference is basically patient in the type 7 cluster that had a more a bit more utilization compared with the 4, but in terms of patient characteristics, they look quite similar. Excuse me. So in the further analysis, we actually manually group type 7 to type 4. But you may want to ask, what about 6 group cluster, right? Whether that automatically collapse the type 7, type 4, but unfortunately, no, they actually still showing up as 2 different clusters. They might be due to the number of clinical encounters that these patients had in the 2 different clusters. And this is kind of a better way to some extent to digest what's going on within each cluster regarding their care processes. So for example, majority of individuals actually fall in type 1 cluster. So they actually, most of them did not have much of interaction with the healthcare system before their ADRD diagnosis. They had a primary care visit right before a diagnosis was made. So majority of people follow that pattern, and the similar pattern seen in type 3 that actually have 2 primary care visits prior to the diagnosis versus type 5. Those are individuals who likely have periodic visit to their primary care providers. But some other patterns like type, this one is individuals who had a visit to other specialties prior to their ADRD, and type 4 and type 7 are kind of frequent utilizations of frequent utilizers of healthcare services, and most of these visits relate to other specialties. So we looked at, as I mentioned, the patient characteristics across the different clusters, the typologies we identified. We found some differences across regarding patient characteristics across the clusters we identified. So for example, that for age, we found age of diagnosis was slightly higher in the type 3. And for individuals who live in rural areas, they're actually more likely to be in a group with that have more primary care visit versus other specialty visits. And because when we came in this project, we think about like non-Hispanic white versus non-Hispanic Black older adults may follow different care processes, but we actually didn't find differences regarding how those the probability being in a given type. But later on, we did a multinomial analysis. We did interaction between gender and race. We actually found racial differences regarding the proportion of individual belong to one cluster versus other. But that difference is overall only among female individuals. So lesson learned so far. So basically, we identify considerable variations in the longitudinal care process leading to an ADRD diagnosis. Again, this is just like the very first ICD-9 or 10 indication of ADRD in the EHR system. As I just mentioned, that we found racial differences in the care processes, but only among women, and we found age, rurality, and mobility, work mobility contribute to some of the variation we've seen in the care processes. And also, I think this, like the first thing we did is basically demonstrate whether the method we're going to study life course stage can be applicable to analyze EHR data. I think there's some feasibility that being demonstrated through this exercise. But again, limitations, a single site study, because we know the geographic location of field we share practice with UNC, although like we did some analysis, basically we limited our patients are those who have a primary care provider at do so to make sure we have a more complete catchment of all their healthcare utilizations, but still we don't quite know in terms of the completeness of the care processes that we observe in the EHR. And also talk a lot at the beginning regarding the analytical decisions we made in the data management process. And those decisions, we actually have a very interdisciplinary team. So myself as a social gerontologist, we talk with neurologists, we talk with primary care providers, we have also medical sociologists and epidemiologists as a team to really think about whether the decision makes sense, both from a mathematical perspective, but also from a clinical perspective, whether we're actually introduce more bias to the analysis. And also one question we didn't answer specific in the in the data presented today is the extent to which the pathways of care process are associated with a timely diagnosis with AD, whether certain pattern that the certain care process were more likely to an early diagnosis with delayed diagnosis. That's a part I didn't present today. We actually are linking the care processes with the ADRD stage of ADRD stage to see if there's any association there. And also one thing I want to talk about is because this is a study purely based on the existing data, which is EHR, it's just one side of the story. So the bigger in the entire bigger study, we actually, it's a mixed method. We actually interview patients and their caregivers to from their perspective, understand the care processes they followed prior to the diagnosis. So we actually did some qualitative interview, and we also gave them cards to sort kind of a series of events prior to the diagnosis. So those are kind of two examples I want to just share briefly. So those are the kind of the two care processes we learned from the patient and family's perspective, how things were unfolding for them as we're trying to navigate through the healthcare system to find some answers. You can see those are more nuanced than just the color scheme, the patterns we're seeing before. So basically, based on EHR, we can understand kind of the major patterns, but regarding like who initiates the conversation, whether it was the healthcare, whether it's a healthcare provider or the family, those are the nuances that we won't be able to tell based on the EHR. And another thing is, although we didn't see much of a racial differences regarding the care processes patient follow, but regarding the quality of the care, the quality of the communication, there might be some differences between patients' experience who self-identify as non-Hispanic white versus non-Hispanic Black. So again, just want to share that yes, EHR is a pretty powerful data source for us to really understand what are the major care process, but if you think about how to really address disparities, that it's also important to consider other source of the data. It would be nice to actually triangulate data to have a more comprehensive understanding of the issue we're dealing with. So with that, I want to acknowledge my wonderful collaborators across Duke and beyond, and also the funding support I received from NIMG and two internal funding sources. Thank you.
Any questions?
Yeah. Do you use a median measure when you applied method? And to which dimension you optimized the cluster?
Yeah.
Therefore, did you use a Euclidean measure? When you applied the one method?
Yeah.
What was the dimension on which you optimized? Plus,
So I can talk to you maybe for the sake of time, I think, I can explain more details.
okay, I have one question. Did you synchronize the time events for clustering? I mean that there for each patient there is a time sequence of events the events appear at different time points and therefore by the clustering it's introduced a bias or background to the calculation and did you synchronize the events for each individual?
So we didn't specifically synchronize the event, but we only allow individuals all event occurred within the 2-year period. Everyone have observation period for 2 years prior to the ADRD diagnosis.
Probably I have one suggestion. Probably. Instead of using Euclidean measure, you can use relation. And therefore, in this case, you will, when synchronizing with time events, you will emphasize the pattern of, for instance, head disease in 2 years or Alzheimer disease in 3 years or 5 years. It's just.
Thank you.